Welcome to Cultural Competence and Racism in Clinical Health Research. My name is Monnica Williams, and I am an associate professor at the School of Psychology at the University of Ottawa, where I serve as the Canada Research Chair in Mental Health Disparities. I'm also the director of the Lab for Culture and Mental Health Disparities, and I am the clinical director of the Behavioral Wellness Clinic. I'm board certified and licensed in both the US and Canada. So, we're going to start talking a little bit about ethics, and that is the ethics of inclusion when it comes to people of color and clinical research. So, in 1987, the U.S. National Institutes of Health urged for the inclusion of women in its funded clinical research. At that time, people weren't always including women or people of color, and it was just assumed that medical research that was done on white men would generalize to everyone else. But we started getting some signs that this wasn't the case, and so the National Institutes of Health said, hey, we need to try to make sure that the research that's done is a little more inclusive. In 1989, they encouraged ethnic and racial minority inclusion, and in 1993, they passed the NIH Revitalization Act. And so this was made effective the following year and required inclusion and reporting of ethnic and racial minorities in clinical research. And by 1995, they refused to fund any study that didn't comply. So that meant that every study had to have a cohesive plan by which they would include people of color. In terms of inclusion, some people may wonder why inclusion is so important. And in fact, the U.S. Department of Health and Human Services said that it is imperative to determine whether the interventions or therapy being studied affects women or men or members of minority groups and their subpopulations differently. Why is that? That's because treatments may affect different groups differently due to physiological reasons. Further, even if we're not talking about, say, a drug study or a medication study or medical intervention, even in mental health studies, you may find that groups differ in how they respond to a treatment. Consider that many different cultures express symptoms differently of the same disorder. They may have different explanations for illness, and they may find some treatments more or less acceptable than others, which can affect things like expectancy, compliance, and outcome. So, another reason that we have to include people is because it's just the right thing to do. In other words, ethics. Consider that research findings that are not inclusive of people of color may mainly benefit the majority who are being researched because treatment approaches become tailored based on their results. So, in order to fully benefit these groups, research must be conducted to determine what works best with different groups. So, people of all races and ethnicities contribute to the cost of research funding through tax dollars that pay for studies funded by federal agencies. And so it's critical that findings benefit all groups as well. And this is really underscored in what's called the Belmont report, that was the product of a lot of really smart people getting together, scientists, researchers, ethicists, and talking about what's really important when it comes to doing research. And the three fundamental principles were respect for persons, beneficence, and justice. Now consider that North America has evolved its research ethics guidelines from a lot of the world's most famous documents. The foundational document in all this is the Nuremberg Code, which came out of the Nazi regime when they were doing experimentation on subjects without their consent, and it was determined that this was really unethical to do research in this way, and so this could not be a defense for those Nazi scientists. And then out of that came other really important works as well, including the Declaration of Helsinki, and then the Belmont Report, which we're talking about here. And then there were other important documents as well, including the Council of International Organizations of Medical Sciences guidelines, the International Conference on Harmonization of Technical Requirements for Registration of Pharmaceuticals for Human Use Guidelines. I know that's a mouthful. And many other important documents as well. But the thread that runs through all of these is, again, respect for persons, beneficence, and justice. And one thing that we do know is that there is a major health gap. There is a major gap in the health data that we have because research has not always been inclusive. For example, in Canada, we find that there is that people of color or visible minorities in Canadian health data are actually invisible, as the authors make the point. They found in a comprehensive review of the literature that only 5 studies that examine nationally representative data to compare visible minorities with white people on specific health conditions or behavior. So that's not a lot of studies. So we're doing a lot better in the United States in that way than Canada, but this is a really big problem really all over the world. Now, getting back to Canada, many studies fail to distinguish between immigrants and Canadian-born minorities, so that conflates the effects of racial status with immigrant status. And also sometimes what we call the healthy immigrant effect can mask racial health inequities. So in other words, sometimes we see that immigrants to a new country actually do better than is expected and better than their progeny. So that can sometimes mask real differences and problems that we need to address. Also, often visible minorities, also called people of color, are often treated as a monolithic group, which ignores the diversity within this growing population. And so you have to look at differences, for example, by nativity or where the person was born, ethnic origins, and other characteristics. And the older population is even more invisible in the health data than the younger population because more and more people are starting to see how important this is to actually start collecting that data. So what are some obstacles to equal inclusion and outcomes? Well, one study that was done in the UK, and I think that these results are quite applicable in North America as well, found that ethnic equity was considered only a peripheral concern within national healthcare policy. And so even though it was on the books, people didn't really think it was important. Also, it was poorly aligned with other more dominant agendas, and people tended to treat it as a matter of legal compliance rather than integral to meeting healthcare needs. Now, in terms of people on the ground, the managers didn't really feel like implementing, equity was part of their job, and they didn't even feel like it should be part of their job. And also, managers didn't really know how to do it. They didn't have the confidence and skills to address inequities even in their own facilities. So these findings indicate the need to enhance the skills, confidence, and competence of individual managers and teams to improve these structures and processes that support attention to racial and ethnic inequity. Another problem is that there is a long history of medical mistrust and research abuse among populations of color. So, for example, people of color often underutilize healthcare services out of fear of being mistreated, being hospitalized involuntarily, or being used as quote-unquote guinea pigs. For example, African Americans have been shown to have a greater distrust of the medical establishment and mental health care, many believing that medical institutions hold racist attitudes. These negative perceptions may be rooted in historical abuses. For example, government-sanctioned abuses against people of color, such as the Tuskegee Syphilis study. For those of you who are not familiar with this study, it started in 1932, and it was funded by the United States Public Health Service. It was the official title was the Tuskegee Study of Untreated Syphilis in the African American Male, and it's the longest non-therapeutic experiment on human beings in medical history. The study was purportedly designed to determine the natural course of untreated syphilis in some 400 African American men in Tuskegee, Alabama. The research subjects all had syphilis when they were enrolled in the study and matched against 200 uninfected subjects who served as the control group. The subjects were recruited with misleading promises of special free treatment, which were actually spinal taps done without anesthesia, to study the neurological effects of syphilis, and they were informed without their knowledge or consent. And then, when antibiotics became available, they were denied access to those, which would have cleared up their syphilis. So, in some cases, people actually got a little bit suspicious of what was going on and tried to go to other clinics for care, but they were all collaborating, and so they were sent back to the researchers. Now, over 100 people died directly from advanced syphilis. In fact, the researchers really felt that the most valuable product of the study were the dead bodies so that they could autopsy them and look at the effects of the advanced syphilis in the body. In 1972, an investigatory panel found the study to be ethically unjustified and said penicillin should have been provided. The National Research Act in the U.S. was passed in 1974 and mandated that all federally funded proposed research and human subjects be approved by an Institutional Review Board, or IRB. In Canada, this is called the Ethics Board. By 1992, settlement payments of approximately $40,000 were made to some of the survivors, and the President Clinton publicly apologized on behalf of the government to a handful of survivors in 1997. So that was a very sad story, and if that was the only story, well, that would be sad enough. Unfortunately, it's not the only story. There's a lot of bad history when it comes to vulnerable populations and research. For example, there were reproductive abuses of racialized women going all the way back to slavery in the U.S., where Dr. J. Marion Sims, who's called the father of modern gynecology, used 3 female slaves from Alabama to develop an operation to repair vesicovaginal fistulas. Between 1845 and 1849, these women would each endure up to 30 agonizing operations. And only once he perfected the procedure did he attempt this on white women, and of course with anesthesia. He said, I quote, "The first patient I operated on was Lucy. That was before the days of anesthetics, and the poor girl on her knees bore the operation with great heroism and bravery." So again, he operated on 12 slaves in his backyard hospital. And these abuses continue on into current times. There is a long history of forced and coerced sterilization of black girls and women through the 20th century, which was paid for by the state and is continuing up into the present time in the United States jails and prisons. Further, there is sterilization abuse of Indigenous women in Canada. That is an ongoing problem even now, where many Indigenous women who give birth may be told that they can't leave the hospital with their baby unless they agree to be sterilized. You may not have heard of the U.S. CIA-funded LSD experiments, which were part of a program called MK Ultra. This program was launched in 1952 to study mind control techniques, and hundreds of people were given LSD, including many without their knowledge or consent. But subjects included Americans, Canadians, and internationals. Several experiments were done at what was called the ARC, the Addiction Research Center, by Dr. Harris Isabel. One of his collaborators was Dr. Harold Abramson, and these involved high doses of drugs over long periods of time, administered to incarcerated, quote, Negro male drug addicts, unquote, at a research institution. In one paper, the comparison subjects were all healthy, affluent, non-incarcerated white volunteers who got LSD in the PI's private home. So consider that these were very different situations and circumstances where people received these drugs. One former participant, Edward Flowers, said, "They used my ass and took advantage of me, being a young kid and all the rest of that kind of stuff. Back then at that time, for a while there, I was angry and bitter." So another highly unethical experiment was what we might term the Canadian malnutrition experiments on Indigenous children. So these were performed at 6 residential schools between 1942 and 1952. Keep in mind, residential schools were where Native American children were forced to go so that they could be stripped of their indigenous heritage and culture. But the schools were often hotbeds of physical and sexual abuse. Meanwhile, on top of all that, um, the the children who were enrolled in the study were given different types of food that was missing various critical nutrients. Now, the parents were not informed or aware, and and the control and treatment groups of malnourished children were not given adequate nutrition, and so many children had serious permanent health issues or died as the result of the experiments, and yet the experiments continued. So the problem with the Tuskegee study is that the natural history observations continued long after penicillin became available to treat syphilis. But in Canada's case, the basics of alleviating malnutrition were already well known even before the experiments began. Both studies were performed among individuals who were already marginalized and vulnerable, and no one was looking out for the best interest of these research subjects. They had no voice. And one final study that was done more recently is referred to sometimes affectionately as the John Hopkins lead paint study, which started in the 1990s, where researchers were looking for new ways to purportedly protect families from the harms of lead paint in the home. And so what they did was they had two conditions, one where the families were rented homes that had peeling lead paint in them, and then the other condition where families were also rented homes that had peeling lead paint on them, but they were just given this stuff to brush on the walls to see if that kept the lead from ending up in the bodies of the children. So the way they measured how successful their study was to measure the children's blood and look at the lead levels. Now, lead is extremely toxic. It interferes with brain development, and for some reason this made it through the Johns Hopkins IRB, and unfortunately the exposure to lead had a detrimental effect on the children. It eventually went to court, and the judge said the children were being used as measuring tools by researchers or canaries in the mine, and he concluded that the Institutional Review Board had abdicated its responsibility to protect subjects and likened the study to the infamous Tuskegee experiment. So, all that to say, there is a large cultural memory. There is a large cultural memory of historical abuses that persists. I don't know if you've heard of the term healthy black paranoia, but this is a cultural response style based on experiences of racism and oppression in U.S. society. So, in other words, a lot of black people are a little bit suspicious most of the time. And so, this type of attitude you will often see among people of color when faced with the prospect of participating in research. Not to mention, on top of the history, they're also dealing with actual experiences of discrimination on a regular basis, and they don't have any reason to think that researchers are going to be any different than the way other people treat them. So, researchers, when working with people of color, have to understand, mistrust, and validate their participants' concerns. So, what can we do about this? Well, we can give lots of good empirically supported advice. I mean, here's a few examples of advice. It was published. It's all good advice. But the long and short of it is implicit bias and structural racism interfere with implementing all of this good advice. And this is why so often things don't change. People have biases, and these biases end up becoming barriers to participation. And when I say biases, I'm not talking about the participants, who certainly are often wary, but also medical researchers who may exclude people of color due to assumptions that they wouldn't be good participants. Actually, one research study found that people of color were just as willing to participate in research that wasn't invasive, but that they were excluded because of biases that the researchers had. Also, they may be excluded due to biased recruitment methods when recruitment consists of things like maybe bringing in people from the researcher's own private practices for research that is maybe potentially very beneficial, or recruiting disadvantaged people for studies that are quite dangerous using coercive methods. And so this is what causes these disparities. Also, we know that clinicians do have biases. One research study of 40 primary care clinicians and 269 patients in an urban community based center measured clinicians' implicit general racial bias and recorded their race and recorded audio tapes of visits. And what they found is that for black patients, there was some anti black bias. Racial biases predicted more clinician verbal dominance, lower patient positive affect or mood, poorer ratings of interpersonal care, race and compliance stereotyping, longer visits, slower speech, being less patient centered, and again, they got poorer ratings of interpersonal care. So, so all that to say, physicians have to recognize that their patients are unique human beings, and that they should really work toward patient-centered care. The problem is that these biases are more likely to kick in when clinicians are stressed, busy, and not paying attention, which is often the case these days, as doctors may be overloaded with patients that may be double and triple booked. So they're not paying attention to how they treat each person, and as a result, these biases take over. And you may be wondering, okay, well, that doesn't sound great. Maybe your doctor, didn't pay as much attention to you as you wanted. Is that the worst thing that could happen? You're not dead, right? Well, actually, studies show that some people do end up dead because they were not treated fairly by their clinicians. Here is a study where they looked at physicians' recommendation for life-saving coronary artery bypass graft surgery by patient race and gender. And what they found was that after controlling for all medical factors, there was a huge disparity in that black males were only getting referred for the surgery at half the rate as everyone else. So there was no bias. So the white people were all getting these referrals properly, and black women were too, but for some reason black men just we forgot to refer him or whatnot. Now, I don't think the doctors were all sitting around thinking, hey, how can we really get these black guys? But there definitely were some biases whereby they just weren't considered important patients, and so they didn't get the care they needed, right? And so this is how it works. With healthcare disparities, you have problems like persistent discrimination, which in and of themselves are a cause of physiological and psychological stress, which causes health problems. But then you also have this problem called clinician bias, and this causes two kinds of problems. One, it causes disparities in clinician decision making, like we saw with the referrals for the heart surgery. They're making bad decisions, and this ends up causing racial healthcare disparities. And then also, you have disparities in clinical communication. So they're not treating their patients with the same respect, or they're not communicating to them in a way that resonates with the patients. And so you have negative patient reactions. And when that happens, when you don't like your doctor, well, people just don't follow the doctor's orders. And then that results in racial healthcare disparities, which results in racial disparities in health. So what do we want to do differently here? We want to think about how we're going to approach this at the ground level. And there's kind of two philosophies that people might employ. There's one called ethnocentrism, And this is basically a set of beliefs and values that supports judgment about other ethnic, national, and cultural groups and events from the observer's own ethnic, national, or cultural group outlook. This is not the perspective we want because it narrows our perception of others. In contrast, multiculturalism is a view that not only encourages recognition of equality for all cultural and national groups, but also promotes the idea that these groups have the right to follow their own unique paths based on their own systems of beliefs, and that all of these groups bring something important, interesting, and valuable to the table. So how do we implement this when it comes to research in healthcare? Number one, culturally competent research staff. So the study personnel should be genuinely committed to people of color and their mental health and be adequately trained and culturally informed in assessment and treatment. Areas of concern could include problems like a colorblind approach, where you just sort of say, I don't see race or ethnicity, everyone looks the same to me. Well, that's not helpful because everyone is not the same. Further, microaggressions are a problem. These are small covert acts of racism or subtle ways that people are mistreated due to race. And then again, systemic exclusion of people of color as research participants. And this has to be explicitly addressed so it doesn't happen. Diversity is super important. You want a diverse team, not just diversity at the lower tiers of the research study, but diversity from the top, from the principal investigator and the key investigators and key consultants, as well as, to down the file to your undergraduate research assistants, right? We want diversity throughout. And ongoing training is critical. Consider that previous generations of researchers and clinicians may not have received any diversity or anti-racism training at all. So they need they may need more training, and things change, and so ongoing training is necessary. You don't become culturally competent over a lunch webinar. It's an ongoing process. It is also important to have someone with expertise in culturally informed research methods at the front end to prevent the need for methodological changes later on. So if you design your study with only white people in mind, you're going to find when you go to enroll people of color that it's just not working right. And if you had thought about some of those things on the front end, you wouldn't have to change them later. Further, institutional and individual biases may work against inclusion, as consider that racism and sexism are baked into nearly all of our structures and systems. And so these structural issues are going to need special attention as well, particularly in studies that are not getting the diversity that they'd like to see. And then finally, there's an issue of power and privilege in the research team. So it's important in any team to make sure that people of color have important leadership roles and they're not limited to lower level positions. People on the team should discuss the socio-racial hierarchies present in the larger society and formulate a plan to make sure all voices are heard. For example, authorship agreements need to be equitable, and all people of color need to also be included as presenters and authors. Further, the team leaders should continually seek input from people of color on how the team is functioning to ensure harmonious interactions, and engage in social activities as a group to build trust and cohesion. Because, like it or not, most people live and work in segregated communities. So they don't know anything about people who aren't like them. We talked before about sample size and how sometimes you might need to oversample to make sure that you have enough people in your study. So at the very least, you want to have a representative sample where you want to include people from every different group based on their presence in the population. But if certain groups, there aren't large numbers of them where you're doing your study, and it's important to understand relevant clinical factors about those groups, you might want to oversample them. And then that way you'll have some really interesting, important, and meaningful data about those other groups. And that's also like a second research publication right there. That should make a lot of researchers happy. Now there may be some additional costs associated with oversampling, but it's important and worth it. Next, it's so important to collect demographic information. And this is a big problem, especially in Canada. Well, also, actually, it's a worse problem in Europe. But it's really important to get information on a person's ethnicity and their race, because if we don't collect it, then we can't document the problems that we know are there, and then we can't fix the problems, and we can't tell if our efforts to fix them are working because we didn't even collect the information. So good researchers collect all this information from participants, including ethnicity, race. You may want to check acculturation status, right? Because sometimes people come from other cultural groups. They don't identify with the dominant culture, and that's going to maybe change the outcome of your study as well. We want to also look at immigrant status, languages spoken, age, religion, sexual orientation, educational attainment, and socioeconomic status, as well as sex and gender. These are all really important pieces of data that can help us make sense of differences that we find. But if we don't collect it, we can't assess it. Community outreach is really important because a lot of times people in ethnic minority communities are not going to be running to come to participate in a research study unless they know the people who are part of it or there's a good buzz about it in the community. So it's really important to create and maintain personal connections with important people and gatekeepers in these communities of interest. And how can you do this? By partnering with church leaders and community groups, participating in community events, like go spend time in the community, buy things in the community, get to know people there, offer free educational lectures, build relationships with local professionals, patronize these businesses. If you're not a part of the communities of interest, don't expect to be welcomed right away. Building trust takes time. And then once you get a person into the clinic, there are a few other things you need to consider as well. Incentives and compensation. Are you expecting them to participate in the study for free? Pay them. It shows that you respect them and you care about their time. Although paying people too much could be coercive, so you want to have to think carefully about how much they should be compensated. Personalized feedback. What did you learn about the participant that could be useful to them? They'd like to know that. Accommodate their lifestyle and family needs. So, for example, things like childcare could be important. Maybe your study wants to offer that. A comfortable environment, right? So when they come into the clinic, it should be warm and welcoming. Shouldn't feel like a cattle call, right? Think about where you'd like to spend your time. And also think about your participant. What sorts of messages might be embedded in the environment that could make them feel like you've thought of them? Think about cultural themes in your decorations and artwork. Informed consent. This is really important. A lot of times, informed consent documents look like a bunch of legal paperwork. They shouldn't. They should be understandable. They should be a low reading level. They shouldn't be too long. It should be conversational, informed consent. And most of all, participants need to know that when they sign it, they're not signing away their rights. They're actually signing the informed consent to make sure that the researchers are doing their jobs. And you may get participants that have misgivings and fears. You don't want to just say, oh, you got nothing to worry about. You want to validate that. You know why? Because they do have a lot of reasons to fear. If all of my the time I spent talking about research abuses means anything, it means that they have reason to fear. And so validate that. Say, yeah, I can understand why you'd be anxious. And we're hoping we're not going to treat you that way in this study. That's not our goal. But I know some other studies have mistreated people like you. And then finally, review of progress. Researchers should continually assess their diversity goals. They should make sure that they're working by checking periodically on the diversity composition of their participants. They should reduce ineffective methods and retain or increase effective methods as the study is ongoing. So that can be done again through regular team meetings to target their numbers and meet diversity goals. And you do all that and you will have an awesome diverse study. So thank you. That's all I have for today. If you'd like to reach me, there's my email address right there, monica.williams@uottawa.ca. And there's my website that's got all of my papers and things. I'm going to give you a list of recommended readings. right here, and you can get them you can download them for free at my website. These are more readings about culturally informed research, recruitment, and retention. Thank you very much, and that's all I have for today.